Our moderator today is Daren Smith, Vice President of ASC Solutions at Surgical Information Systems. Joining him are our panelists. We have Alfonso del Granado, Administrator and CEO of Covenant High Plains Surgery Centers, Beth Russell, Executive Director of Knoxville Orthopaedic Surgery Center, and Katie Pierson, Administrator of Spicewood Surgery Center. We'll have our panelists introduce themselves as we begin discussion. I'll now turn the floor over to Daren. Daren?
Good afternoon, panel. We are going to celebrate our National ASC Month by having three of the more successful administrators that I know go through some questions, just some quick back and forth and panel discussion about the achieving success in the surgery center. So we're going to start off with some quick introductions. Rob already covered who you are. I just want you to introduce yourself a little bit. Tell us how you got to where you're at now. So we'll start off with Beth. Beth, you want to introduce yourself?
Sure. Beth Russell, Executive Director, Knoxville Orthopaedic Surgery Center. I've been in this role for almost 7 years now and worked at a local hospital as a director of surgery for 5 years prior to that, where I worked really closely with the orthopedic surgeons that I now work for. And I'm very excited to be here on the panel today. Thank you.
Thank you, Beth. Katie.
Hi there, Katie Pierson. I'm the administrator at Spicewood Surgery Center. I've been here for over a year, been an administrator for about 2 years now, and part of the ASC industry since 2017, so about 6 years now. And I'm also excited to be here.
Fantastic. Alfonso.
Hi, I'm Alfonso del Granado. I'm the CEO and administrator for Covenant High Plains Surgery Centers. Been in healthcare management for 25 years, the last 10 in ASC, before that in hospital administration.
All right, and I'm Daren Smith. I'll be the moderator today. I'm the Vice President of ASC Solutions here at Surgical Information Systems. So one of the best parts about my job is I get to work with marketing and get to do some of the webinars, demonstrations, and some of the panel discussions like this one. So our crack group of administrators today, I'm going to talk a little bit about that evolving landscape of the surgery center, and boy has it evolved over the last few years. And that's going to be actually our first question that we address today. Looking at the industry itself, the entire ASC industry, what do you think has been some of the biggest changes that we've had since COVID? When we crossed that crest and we were starting on our way back to being normal, what would you say are the biggest changes that you've seen in the industry? Katie, why don't you start us off there?
Sure. Well, nothing new now, but definitely since the pandemic has started to calm down a bit, I think the ASC industry is really being looked at more and more for those higher acuity cases being done on a consistent basis, not now just since we are in a pandemic. So it's trying to push the payers, specifically Medicare, to really understand that they can be done here, be done safer, be done cheaper in some respects. So that's definitely one in particular. And then with that reimbursement for certain procedures, you know, I work for pain management, and we're seeing a big disruption in injections and how they're getting reimbursed. So, you know, that's not necessarily something new, but it's definitely something that's been creeping up for us specifically.
How about you, Beth? What has your impression been of the industry?
I think the surgical volume increase to the ASCs, things coming out of the hospitals, was huge. And once that happened, no one wanted to take them back to the hospitals. That's been the big thing for us, is the physicians want to do as much as they possibly can in an ASC. And I think one of the things that was probably really eye-opening for us was how fragile the supply chain could be. And we're still kind of seeing that come back, just in how things, one day you can order them and the next day you can't, and how the prices are increasing, and things we just took for granted that you just never thought you would see in this industry.
Alfonso.
Well, I have to agree with Katie and Beth. We've experienced exactly those two issues. And I think probably the other leg of this particular stool is labor. We're all suffering from a tremendous labor crunch. We have to bend over backwards to keep our staff satisfied without the ability to significantly increase our compensation, because we just don't get the same kind of reimbursement that a hospital does. So whether it's coming in early with a cappuccino machine and serving up some treats for the staff, or bringing an ice cream truck on a hot afternoon, we're trying to find creative ways to keep the staff satisfied and keep them productive.
And we're gonna address that a little later in the discussion as well, because I'm interested in hearing what all three of you are doing to address all of the staffing issues that we've had. So now let's take it off the global level and let's bring it down into the personal level. So at your individual ASCs, what changes have you seen since the crest of that of the pandemic and going forward? And we'll go in reverse order this time. So we'll start with you, Alfonso.
Okay. Well, obviously the challenges that everyone mentioned directly impact us. Our focus has been a little bit different in that we have actually been shedding some case volume. Some of the lower acuity, higher turnaround cases, including pain and GI, have been jettisoned in favor of higher complexity, higher acuity cases. We're working in conjunction with our JV partner, the hospital system, to transition what for them is lower acuity and for us is higher, bring that into the OR. We have invested in a total knee robot and a Da Vinci general surgery, urology and gynecological surgery robot, as well as essentially trying to find anything that we can that's authorized that we can bring over to our surgery centers that requires greater level of expertise and more resources than we used to expend. No more bread and butter cases for us, unfortunately.
Mm-hmm. So where are those cases going? Where are those being pushed back to?
So a lot of them are being done, for example, our pain cases are now being done primarily in surgical suites that our partners have at their offices. And GI cases, the same thing. Also, a lot of them have migrated to independent, solo, or single specialty practices, including GI and pain as well.
Fantastic. Interesting. You know, you hear everyone talking about, oh, how do I get more? How do I get more? How do I get more? And now, you know, we're starting to see, okay, I got enough. What gives me the best outcome, both clinically, financially? Yeah.
Oh, I'm sorry, I apologize. Our community is relatively small, so the number of available personnel is very limited. We have to maximize the impact of the available hours and staffing that we have in order to be able to get the best results.
Oh, fantastic. How about you guys, Beth? How's Knoxville?
It's actually very, very similar to what Alfonso said. With that huge shift inside of service after COVID, we ran out of ASC space. We didn't have enough room that for all the physicians that wanted to come and all the patients that wanted to come. And so we're actually, we have one procedure room. So we're all orthopedics, and then we also do pain management, one procedure room. And we're currently in construction phase now to convert that room into an OR. And so we're sending those procedures back to the clinic. Our physicians have 2 surgical suites and procedure suites at the office, and making more room for the larger surgeries here. Total joints have obviously been a big increase over the last few years. And with this renovation that we're doing now, we're going to be bringing more spine in.
So is that primarily what you're seeing as the shift is the totals in the spine?
Well, no, we've seen an increase in everything. I would say the greater percentage in total so far, and hopefully spine, but we've seen an increase across the board.
Oh, fantastic.
Yeah, spine, joints, and cardio seem to be the 3 biggest, newest influxes for sure. Yeah. Well,
how about you guys at Spicewood?
Yeah, almost piggyback, but not quite. We've had to consolidate what procedures we do on what days, specifically with the anesthesia issues that came up. Not only the lack of providers and the costs that they're all, you know, requiring, but also again for pain management, Medicare's not reimbursing the anesthesia services anymore. So what we've done is consolidate our bigger procedures, the ones that really require the MAC, the propofol, that kind of stuff, into 1 to 2 days. And then we do moderate sedation now our other days as it's allowed, as we're able to try to offset that issue. So yeah, that's been our biggest change. And we're going to renovate as well to get more bays, because we need more pre-op PACU bays to get more procedures into our ORs.
Right. So you increase the throughput. Where are you going to put all these people? And construction has its own set of challenges. We heard that during the pandemic too. Is why aren't these surgery centers adding on? And if you look at construction costs and, as you mentioned, the supply chain issues, we thought we had it bad in healthcare. It's just as bad, if not worse, in the construction industry. So it wasn't quite as easy as it seems. And with all of this this change and the evolving landscape that we're in with bringing on these higher acuity cases, what types of things have you brought into your systems to help with that, to make it easier for your staff, to make it easier for your physicians and things like that? Alfonso, you want to jump in on that one?
Sure. Actually, and this is not a shameless plug for you folks, but we just implemented CIS at our surgery center. We had previously been on Vision, but not utilizing the EMR. And it's just, where I came from in Chicago, I had tremendous amount of data available. So I could case cost and model and do efficiency studies very quickly and pinpoint places where we could do better. Here, everything has been on paper for forever, and it just takes a tremendous amount of work. I've actually had interns from the local college, from Texas Tech, in statistical analysis, mathematics, and systems analysis, coming in, essentially converting stacks and stacks of paper into usable data that we can to help us implement some efficiency programs. Bringing CIS online, and hopefully next year, I'm sure by the middle of next year, putting the EMR into use is going to help us have that data available quickly and easily. We won't have to have an army of interns parading around the center anymore.
Right, right. Katie, how about you guys?
I don't want to shamelessly plug y'all either, but you know, but I was thinking, what have we done to make it, you know, to help offset some of these challenges? And, you know, I'll say it, the CIS program has 2 things that we've implemented most recently within the past year that have really been game changers for our providers, and especially the anesthesia providers, who may not even know that they want it until they have it now. But both the Nextamatic devices that pull over the vitals automatically, now I'm attracting CRNAs more than ever before. They'll want, you know, so not only am I getting them, but now they're telling their friends, oh, if you go to this place, you basically don't have to chart anything. You know, it's so minimal. So I'm getting people come to me saying that kind of stuff, which is wild comparatively to, you know, some of my counterparts out there in the world. And then on top of that, with the CIS anesthesia module, again, not trying to plug CIS, I promise everyone here, but it's so easy, again, for the anesthesia providers. They just go in, they click a couple buttons, and they all keep telling me that they thought the computer was going to, you know, take time out of being able to care for the patient, but now they're saying to me, I can't imagine not doing this. And a lot of the younger folks coming out of hospital systems who are using computer-based systems are enjoying that synonymous flow for them in work. They're used to the computer now, so that's been actually really helpful to offset some of these challenges that we've had.
You want to get your shameless plug in there, Beth?
Absolutely. I'll kind of take a different approach, I guess, in looking at bringing those larger cases on and kind of moving cases back and forth out of service. We've increased a lot of supply costs and a lot of capital costs. And so CIS Analytics, with the case costing module and all of that, has helped us be able to pull out some pretty good case costing data to get in front of the physicians. And so that's important when we're going to try to decide, like Alfonso said, which cases you can do, which need to go somewhere else. And our physicians have been very receptive. You know, they really want the data, they want to see it. And honestly, they're surprised sometimes when we show them that costs how much. Well, I'm never going to use that again. They just don't think about it. They just use things and they just want what they want. And so they're very engaged most of the time. I love when I have meetings and we talk about case costing, and then I've got 5 doctors in my office the next week, like, okay, let me see mine. How much is my case? How much is my case compared to my partner's case? So I really like CIS analytics.
Yeah, that inherent competition that you can gain just by posting some of that data. I always enjoyed watching that happen from a distance, of course. So one of the things that all 3 of you mentioned in how you're going about these challenges was automation. And we've seen a huge increase, not only what automation is offered by software providers, but automation even outside of that. So I'd be interested in hearing what sorts of automation, both software and other types of automation that you guys are using to help with the gaining of that efficiency that you want at your surgery center. Why don't you start us off there, Katie?
Sure. Well, we utilize CIS, so obviously I'm going to use this as my example. However, I have used other EMR systems that offer things like this, so I know they're out there. But for sure, from a preoperative standpoint, we push out the patient questionnaires for them to fill out. So then when our PAT folks are calling, I really only have them calling now the people that have answered egregious yeses or have, severe history. And then also it gives them their instructions as well. So, we're not spending as much time on the phone, which is such a transition for a lot of folks who are used to giving every single detail to every single patient. And I find myself having to remind them, yeah, but your patients are probably not going to remember anything you've told them anyway, so you might as well just push it out to them. So that's been one. And then on the post-op call standpoint as well, it pushes out that post-op questionnaire. And again, we ask the patients if they want a phone call, and then if they don't, we're going to push out the questionnaire. And then it's only if they hit, again, a certain yes to things that we're following up on it. So it's just been really helpful to be more efficient in which patients that we're taking care of for that.
Alfonso, what are you guys using for automation?
Well, we are using, I won't say the names, we are using competing products, but we're looking to get rid of them because the capability already exists within CIS. So we use automation for physicians to be able to schedule their cases themselves in our center. Obviously, we still have the final say based on available resources that they may not be available, but they're able to schedule to their blocks. We do have a patient portal, which enables obviously patients to put in their histories, as well as make payments, which is phenomenal. It certainly takes a lot of time away from our staff. And we're looking forward to a feature, Daren, that we may or may not want to discuss right now regarding the algorithm.
Yeah.
Okay. I'll speak a little bit. What we're looking forward to is an upcoming feature that will allow you to set up rules so that the automation will contact patients based on variables that you set. My ideal, for example, would be to have, if I need a cardiac clearance on a patient, I'd like the system be able to contact the patient and let them know ahead of time, hey, did you get that cardiac clearance? Because, we need this before you have your surgery. Some things are, labs that might be the day before, a couple of days before. Other things like a sleep study might take a week or 2 to get booked. So we don't want to lose those cases. We don't want to delay them. We would love the system to be able to jump in and be able to increase the number of touch points and have variable lengths, intervals between those touch points for patients based on the data that they've entered into their history.
Yeah, well, we're looking forward to that as well, having the opportunity to build something like that. Because
I don't want to put you on the spot here.
Yeah, we believe that's a game changer. We believe if there is a way that you can incorporate your care plan into some sort of automation, whether that be machine learning or active AI, and be able to push that information out without having to intercede in that, simply getting a list of things and saying, yep, that's what we need, and clicking it through. That will be a great source of efficiency and a great source of nursing time, because how many times are your nurses on hold trying to get something scheduled, or trying to get through to a patient, calling them 6 or 7 times to say, listen, we have got to get you in for a cardiac clearance or you're not going to have surgery here. So we see how much time gets spent on that, and it's definitely something that we look forward to as well.
It's true. I was
Beth?
so excited to save time for my nurses, not having to call them to give all the instructions and gather all the information, so they can spend the time doing all of that. So if I can even save more time for them,
right,
that would be even better.
If I may, just one more thing, something that we're
Mm-hmm.
already building, and it's the part of the capability, the interface between CIS and NV, is the ability to essentially have the system place automatic orders for you. I mean, you still have, they're still in your basket and you have to check them off, but based on your par levels, have it look through your vendors, find the best price, and refill your par level without your having to go and do any of this manually.
Yeah, we have that too. That's very, it saves my materials manager. I don't even have a full-time materials manager because I don't need one for that reason.
I love walking into those surgery centers that haven't quite figured that out yet, and you go to the materials manager's desk and it's just filled with Post-it notes.
Right,
all
right.
around the monitor, right? We need this, we need that, we need this. And I marvel that they can keep all that straight, and most of them can't. So I marvel when they can get it right. All right, Beth, well, we're getting around to you. Beth, automation in Knoxville, what are you guys doing to help with that efficiency and reduce the amount of human touch points that you have to have?
One of the biggest things for us recently, outside of the things Alfonso and Katie said, because as CIS users, we do all of that as well. Our physicians recently went on to an app that they use on their cell phone for their op note dictation. Prior to that, they were picking up the phone, calling, doing the dictation. We were printing it out, giving it to them to wet sign, scanning it back in. And so it was a push to get them to do it. They, everyone hates change, physicians hate change. But I had a physician tell me a couple of weeks ago, and he was probably the last to adopt it and was the biggest one that didn't want to change, told me it was life-changing for him. And so that has been awesome, and awesome for my staff as well, because they're not having to touch it as often. The doctors dictate, review it, make their edits, and electronically sign it, and then it goes straight into CIS, and we don't even have to touch it. So that's awesome. One thing we're working on now, Daren, and looking forward to, as Orthopaedic Center, we have lots of vendors, lots of orthopedic sales reps that come, and we need to notify them of lots of different things, what trays we need, what grafts we need, what instruments we need. And so we're really excited about the new upgrade, where they can have access to CIS on their phone, a HIPAA compliant, obviously, and they'll just see the information that they need. So we are meeting tomorrow morning actually about that, to kind of get that set up on our side.
Fantastic. Yeah, wherever we can find those little pieces of automation. I think every other industry in the world has proven that automation breeds efficiency, and healthcare is kind of the last one, the last bastion where we're actually the majority of healthcare is so incredibly manual. And that brings up a good point as well. That kind of leads us into our next part of our discussion, is that's a lot of change. Automation presents a lot of change, and change is difficult for our physicians, it's difficult for our staff, it's difficult for ourselves. We find ourselves mired down in that trap as well. So I'd be interested in hearing how you introduced that automation, and what kind of response you got, and how did you take away that fear of, oh my God, I'm going to be replaced by a machine, right? So we'll go in reverse order this time. Beth, what can you tell us about you being the change agent?
Yeah, well, I think speaking on what we just did with the physicians, and we did the same with staff when we went live with the new EMR, is we clung to and found those that wanted the change, the ones that really like computers, they're very tech savvy, you know, the younger physicians right out of school asking for this. They were the first adopters and they learned it. And then they helped kind of spread it out and tell, man, this is great. And you got to look at this and look at this app. And so then I would have other doctors coming and ask me, like, Dr. So-and-so showed me this. How can I get that on my phone? And kind of the same way with the staff is, you know, we trained a smaller group in the beginning, train the trainer, and the ones that get excited about it, and then they kind of help roll it out to the rest of the staff.
So how do you identify that champion? Is it just through observation, or are you asking around to see who that might be, or what's the best way to find that champion?
Usually my management team, they know their employees. And so, you know, they know the ones that, oh, so-and-so will love this, or this person's going to be our negative Nancy, you know. And so I kind of leave that up to my managers to tell me who would be the best to train first.
Active listening, I do believe, is what the official name of that is. How about you guys, Katie?
Yeah, just to, I guess, continue on from that, on not only identifying your early adopters, but I also find the sustainability part to be as crucial as well. You know, you get everyone excited to get it implemented, and then, you know, something goes wrong, or, you know, it just starts failing, you know, according to everyone. So I don't know if you can already tell from my personality, but I just try to continue that positive, you know, cheerleading, like, okay, let's figure this out. Let's sit down. Let's, you know, work through the problem, because it's not going away. I will say that we'll try something just to get people to start using it, and then it never actually goes away. So then I think people have started to see that my trying something usually means that it's just going to keep going. And then obviously, as you're collecting the data to support any cost savings to the higher stakeholders who can then hopefully really embed it into the system is key as well. So the earlier you can get that data in front of people, I think the faster it is to kind of really integrate it fully into your system.
How about you guys, Alfonso, with the agent of change that you guys are?
Well, Beth and Katie kind of pretty much covered the entire topic of change management. So all I can do is just reemphasize what they said. Finding your early adopters for sure. Your champions, getting the buy-in can be really rough with some people, but eventually they do have to come on board. So changing the conversation from why shouldn't we do this to why should we do this, and getting them to also acknowledge it. And that can be figuring out the cost savings or the losses from not implementing a program. Every change is going to be difficult, and not everybody's job will be made necessarily better after a change. So you also have to be very honest and very realistic and transparent with your staff. If you lose credibility, eventually they'll just stop buying into your proposals. So being honest, positive, absolutely, just like Katie. I wish I had more Katies there, but being very realistic. And I guess one other thing, I have stopped a couple of programs based on a no-go from key team members, and making sure that you should be celebrating your failures as much as you're celebrating your successes, because it shows everybody that, yes, if in fact this turns out not to be for us, then it's not going to get shoved down our throat. We do have a say. We do own this project.
When you do have a say.
Very well said. I appreciate that. Very well said. In this, the landscape that we're in now, and we've tried to gain some of those efficiencies through automation and through change activities and things like that. Inevitably, there's going to be that thing that comes and smacks us in the face and says, nope, no longer can you be efficient. You have to follow this regulation. So we've seen a lot of regulations, statutes, and rules come onto the surgery center environment. A lot during COVID, even some trickling after COVID. How have you guys been able to address some of that changing environment when it comes to the reporting that you have to do, the requirements for no surprise billing and things like that? We'll start with you, Alfonso.
Boy, that's a tough one.
Yeah.
I think it hasn't impacted us as much because we have been already doing more than we had to in many instances. Honestly, it's basically the cost of doing business. I've had some really honest, I have 43 physician partners, and we've had some very honest conversations about, well, you get used to this being part of the cost of doing business, and understand that we will obviously continue to work and find other ways to improve our profitability, but this one is just something that has to stay.
Mm-hmm. Yeah, we hear that all the time. People are constantly asking us, so do you think this OAS CAPS thing's going to stick this time? And I sit on that committee with CMS and ask it, and I couldn't even tell you if it's going to stick or not.
Yeah.
So there's just so much that we don't know, and it once again comes down to the last minute, and then we have to start planning and addressing those things. How about you, Beth or Katie? Anything to add to that?
Yeah, I think speaking on OAS CAPS and kind of exactly what Alfonso said, don't wait to the last minute. We've been doing it for several years and we've not been required to. And so it just makes it easier when it is required that we're not scrambling at the last minute to find that third-party provider that has to help us with it and educating staff and getting the patients used to it. And I just think it's important not to wait to the last minute. And for us, another initiative that we did that it's not required is leapfrog survey. We've done that since the beginning, and it's voluntary. But the driving force kind of for me for that was ASCs have great quality of care, and I just think as many avenues as we can get that out there with different, patient satisfaction surveys and patient reported outcomes and leapfrog surveys and things like that. I just think we should all get involved on the front end before we're forced to, basically.
Is that something you market to your community? The survey results and things like that, is that something you use to market to physicians in your community?
We have not done that. We've used some internally, I guess, from physician to physician practices that do referrals to our group, but not actually to the community.
Okay, very interesting.
That's on our list.
There you go. Katie, how about you in this regulatory landscape? What do you guys got going on?
I mean, let's be clear. I have read the 960-page, CMS report that just came out. So I definitely try to make sure I'm following all the rules. And OAS CAPS doesn't seem to be going away at this moment. So it will be required as of January 1 to start collecting, so you can report it for the following year. And but kind of on the flip side of Beth, I'm a rule follower to the T. But my problem is when I don't agree with it, I will wait until the last possible second to do it. I'm not a fan of this, very lengthy questionnaire for our patients because I don't feel we're going to get the quality data that I am used to right now with the surveys that we're providing. So I'm very cautiously waiting. I'm slowly slow boating that one for sure. And I don't know, it probably won't pay off because we'll be scrambling for sure. It's a risk I'm willing to take at this moment because I'm usually an early adopter when I believe in something, and this I just can't seem to get behind. So I guess again, I will do it if I have to do it. And then for things that I'm not a firm buy-in to, I'm gonna wait. And it's so expensive. It's so expensive. Right now I'm passing something out that's free. And now I have to go through a third-party vendor that's going to cost me, thousands of dollars. So I'm also not looking forward to that.
To get less quality information.
I mean, from my understanding, from my perspective,
Right.
so yeah.
Yep, that seems to be the overarching theme I hear from every surgery center is it's not going to go well.
I mean, if CMS, AAA-HC, somebody walks in my door today, they're going to see that we're following all the rules that they've required as of today. But sometimes I do find myself waiting until the effective date to post the thing.
I don't think you're alone on that.
Yeah.
So something we probably could have spent the entire hour talking about, but we're going to save it for the last 15 minutes here, is staffing. And we've all seen the numbers. I don't care where you're at, and we have a good mix of people on the screen right now. You're experiencing staffing issues. Whether that be having trouble competing with staff, there's staff that you want to grab but you can't because the hospital is paying them a $15,000 bonus, or anesthesia issues, and all those issues that have surrounded staffing. I want to start with a question for the three of you, and that's about recruitment. And what are the things that you can offer that you tend to lean on to get staff to come to your centers over going to the hospital and making more money or those types of things? So Beth, why don't you start with what you guys are doing? How are you getting staffed?
I think we try very hard to sell the ASC lifestyle and culture. It's just different than the hospitals, and we are lucky to have a building full of staff that started at the hospital, and so they know the difference and they can talk to their friends. And basically we try really hard to be flexible, drop your kids off at school, come in, leave to go pick your kids up from the daycare. I have my managers that are just very good at being flexible with their staff when they can, and just that ASC lifestyle, no on-call, no weekends, no holidays. And we do a lot of employee appreciation events. We try very hard I want people to love their job. I want them to love coming here to work. And so working on the culture is very important.
Do you get a lot of personal referrals? Do you find that as a really good way to get good employees or get that word out? Yes,
we do. Personal employees, some are our employees referring their friends, and then also some doctors when they, working at the local facilities, local hospitals, and they know someone that's really good, they'll send them our way too.
Alfonso, I know you guys have competed in you call it a smaller community. It's not a really small community, but it is a smaller community. How have you been able to compete for staffing?
So obviously money is always an issue. I had mentioned some time ago that we just lost 3 techs. They all got $15,000 bonus for joining the competing health system. Of course, it's spread out over 2 years, and if you actually do the math, after 2 years, there'll be money behind. But what are you going to do? Definitely what Beth said, employee appreciation. And it's not just, yes, we do things like the ice cream trucks that I mentioned, or cappuccinos, or we'll have some appreciation events of different kinds, but it's also daily appreciation, right? Whether it's a huddle or listening to people. I will sit down in my office and listen to somebody complain about something for an hour and be supportive and help them walk through the problem. And almost invariably, even if I'm not able to solve their problem, they still feel better at the end of it. So it has to be real appreciation. It can't just be money that you're throwing here or there. It has to be you putting of yourself into the job. I think that the job of an ASC administrator today is more self-sacrificial than it has ever been. If you're not prepared to do more for your employees than they do for you, then you're not going to be successful in this job. I think, again, Beth mentioned personal referrals, but that's the heart of it. Nobody's going to refer somebody over to you, assuming the money is more or less adequate, unless they believe genuinely that this will be a better place for that person, because they have to have faith in you. They have to actually believe that this is the place where that person is going to thrive. If you have a job culture where people come in and they're fine, it's okay. They come in, they do their job, they go home, they're getting paid. Nobody's spitting on them. Hopefully, nobody's throwing a scalpel at them. But that's not going to be enough for them to sell it to the next person, because their own credibility is on the line with their friends and colleagues if they try to bring you over. So you have to have employees who are engaged and who are real promoters for the center. And as Beth mentioned, your physicians as well. They really have to be people who are actively engaged in your business.
Oh, and left Katie for last. Anything to add, Katie? They covered it very, very well.
You did, but you know I'm going to add.
I know you're going to add.
So we've had to get very creative over this past year specifically because we lost all of our scrub techs to the hospital. And then I could not find one within a 50-mile radius, and I live in Austin, Texas. So it felt impossible. So our PRN scrub tech actually offered, she agreed to, once we figured out we should do this, to cross-train our nurses to be scrub nurses. And it has opened up such a world of opportunity now for these nurses that they never even thought of before. So it's such a great venue for that at an ASC, because you can do that kind of stuff, right? we just have that capability. So not only have we cross-trained, now most of our nurses, I don't even have a scrub tech, and I'm not looking for one because our nurses really enjoy it. They're like, don't hire a scrub tech. We really like doing this. We like being a part of this. And they rotate through. And I guess to kind of piggyback off of that, all of my nurses have cross-trained to every role here. So, no one is pigeonholed into any one role in case someone is out, or, for that reason, we've had some great retention because everyone keeps saying how they're never bored. Like we get to do something different, something new every day. And I have a nurse that's pegged as the infection control nurse. I have a nurse that's pegged as the employee health nurse. I have a nurse that's pegged as the quality nurse. I have a nurse, everyone has a role plus another hat. And in the hospital, we always made fun of that as a daunting thing, whereas now everyone sees it as almost like this badge of honor, like, ooh, I get to also be this and do this. And no matter what, it's building their resume and their experience. And now they even have more vested into the facility. Right now, they're expected to do more, expected to be part of it more. So we have for sure implemented peer interviewing, because I can sit there and sell people on it all I want to, but as kind of Alfonso was alluding to, you have your staff talk about the autonomy now that they have in their job. They have a say at the table, even, no matter what the role is. And that's probably the number one thing I hear over and over from my staff is, Katie, we bring something to you and you actually do something about it. We've made so many changes based on our recommendations, and this never would have happened when we were working in the hospital because they're such big conglomerates, right? So you have to go through 18 committees to get something done, whereas in an ASC, one, maybe two, depending on how big, or, if you're part of a management company. But even with that, the team is seeing a lot of their own input getting implemented. So.
And that's a great point. I love that you're cross-training too. That's a challenge that a lot of those single specialty centers have had issues with, is the nurses get bored. You can only do so many 6-minute cataracts before you're just, God, do I have to do cataracts again? And being able to switch them out into pre-op and recovery and scrub and do those kind of things, that is a great way to help with that retention and stave off some of that burnout?
I lost some nurses because we cross-trained. You know, it's not something, you have to be prepared for that. But I will say, you know, you are going to do it. You do have to roll it out across the board. Otherwise, there's going to be favoritism, or how come she has to do it and I don't have to do it, and, you know, all that kind of stuff. So, you know, if it's something you're looking to do, just be prepared that you got to do it all the way through, because you will get those that don't want to, and then it creates animosity. So now anyone that comes in, the expectation, I have a position right now that we're interviewing for, and what's always so fascinating to me is how excited they are. The newbie is coming in. Oh, yeah, that sounds great that we get to be a moderate sedation nurse and an OR nurse and a pre-op packing nurse and a PAT nurse, you know, that's, yeah, so, okay.
Love that. So one of the other techniques that we've seen to help with the staffing and relating to staffing is outsourcing. And I know when we had our preparation call, all three of you were doing some sort of outsourcing. So talk a little bit about the outsourcing that you guys do. How do you monitor that to make sure that you're getting quality, the same quality that you would expect out of your own employees out of that outsourced model? So Katie, why don't you start us off there, and then we'll work our way around the loop here.
Sure. So our linen company, no, I'm just kidding. I don't know, does anybody do in-house linen anymore? No. So that's not the point. Sorry about that. So we do outsource with CIS billing. Their RCM services, and not to put a plug on CIS again, but it is who we utilize. If you didn't know, they have it, by the way, they do. And so they do all of our coding, you know, they put out our claims, they, you know, manage our everything from a RCM perspective. So we do have some business office employees at the facility, a scheduler, a front desk person, and a business office manager. My business office manager particularly is the one that's always in communication with the RCM team. We do have monthly phone calls. They do audits of their own work, and they provide us with that. So there is a lot of conversation around what are we doing, how are we doing. You know, they're usually the ones that are catching themselves and saying, we don't like how that worked out, so we're going to try that again and, you know, fix it. So that's been really helpful. You know, it's hard, and I'm sure these two can also speak to it, that it's anytime you outsource, you know, they're never going to be as vetted into your facility as you are. So you have to be realistic about it as well. So to your point, as long as you're having a really good, open, honest communication with them about what your expectations, what your needs are, and if things aren't going well, I mean, I have fired people over this past year because of the work that was being done, and you know, it's to no fault of anyone else's other than what my expectations were. But we have rectified it, we have fixed it, and you know, I'm actually very happy with the team now and what we're getting. So that's been my experience.
Great. Alfonso, what are you guys outsourcing?
I can't add too much to that. Our transcription, obviously, and coding is currently being done by a third party. That's CIS, although we'll be having some talks about that. And for some types of procedures, the coding is very simple, straightforward. We don't really worry too much about it, but some more complex cases are still having to be done, or rather redone by us. Our number one issue with the outsourcing is timeliness. They've also had some challenges on the coding side. So whereas we used to get 24 to 48 hour turnaround, that became 48 to 72 hour, which really wreaks havoc on our days to bill. So there are a lot of opportunities, but you know, we're not alone in a silo. Every one of our outsourced partners has their own challenges that they're having to face with, and so we have to be realistic in terms of what we're able to turn over to an outside agency, which, like Katie, is not going to be as vested in your success as you are.
Mm-hmm. So if there's anyone out in the audience that has someone who's looking for work, certified ASC coders are in extremely high demand.
Mm-hmm.
Not only our company, but every single management company, every single billing company we talk to. ASC certified coders are in very high demand. Beth, how about you guys? What are you guys outsourcing currently?
Just like Alfonso, the dictation and coding. And we're lucky that we do that through the same company. And so it's a pretty seamless transition and then comes straight into CIS. They do their own outside audits as well, like Katie mentioned, and we do get those quarterly from them. And for the most part, we're very happy with them. Occasionally, you know, you're going to have some weird things that we do send back, but we stand pretty hard and steadfast that we don't let our physicians change that. They don't get that option. This is who we use, and that's our liability that we use them. And so if there's questions, then I definitely have someone I go to, and we've been able to change some stuff with questions, but we only do that if they agree to that.
Fantastic. Well, I personally want to thank the three of you for participating with me today. I always enjoy these discussions. I learn something every time I do one of these. Hopefully it's just as nice for our audience to hear how everybody is doing those things. At this point, I'll throw it back to Rob. We'll see if we had any participant questions and wrap things up. So Rob, did we see any questions come in?
Nothing that wasn't covered during the discussion. I figure we have just a few minutes, maybe quickly go around to each of our panelists, see if they have any final thoughts, and then I will take us out. Alfonso, any final thoughts for you?
Yes, we had, I think Katie had mentioned that sometimes employees are concerned that automation may cost them their jobs or decrease their billable hours. But the fact is, ASC growth potential is so high that any form of automation is going to be not something that where we cut down on expenses, but rather where we're able to generate new revenue, go after new business. So I'm really bullish on growth for surgical centers, but it's important for us to obviously to stay in touch with industry trends. Conferences like these are phenomenal places where you can pick up ideas and information and suggestions for avenues that you can pursue further growth. So I'm really happy to be here, and I'm very happy especially to be working in the ASC space at this time.
Well said. Over to you, Katie.
Oh, for sure. And don't be afraid of technology. It really can be a huge assist to your day-to-day operations. It's helped us tremendously, and you know, I think anywhere that you can, you should. People call me paperless Pierson for a reason. I think I have one binder left in my facility, and it's an emergency binder that you have to have on paper from CMS regulations. So otherwise, you know, I'm thinking we have, you know, little temp sticks that automatically tell me when our temperature is out of range. We have the patient TV tracker, the Nexomatic devices. All my logs are electronic. My paper charting is completely 100%, or my EMR, excuse me, patients charting is 100% paperless. So don't be afraid of it. It's very possible, and it really does help make you more efficient if you once you worked out all the kinks. I'll put that caveat in there.
Terrific, thank you. And then Beth.
Yeah, I just think it's important. Don't ever think you're by yourself. Just network. Just if you're not a member of ASCA, join your state associations if you have one. Do webinars like this. Reach out to us if you have any questions. I just think if you are dealing with something, I assure you somebody else is too. And it's so important to just talk to everybody and see how they're handling it.
Networking, yeah.
Excellent.
Very well said.
I want to personally thank the three of you and Daren for serving as a moderator of this terrific discussion. It was really informative, enjoyable, and quite humorous at times. So thank you both. Thank the four of you. We hope everyone joining us today enjoyed the panel discussion as well. I want to thank all of you for attending. Our wonderful panelists have graciously agreed to make themselves available to answer any questions you may have. You can feel free to reach out to them using their contact information that is on your screen now.